Hello and welcome to this special episode of the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Rhiannon Ashman, Deputy Editor at MIMS Learning, and as you might be able to tell, I'm not in the studio for today's episode. I'm up in Liverpool at MIMS Learning Live North. And although you may be fooled by my accent, which has been honed by 15 years living in the southeast, I grew up down the road in Chester and it's lovely to be back in the northwest. Even more so because I've got a packed episode for you today, bringing you some key highlights from today's sessions, a great opportunity to boost your CPD with some hot topics in primary care. We'll be covering off acute eye conditions, when to manage these in primary care and when to refer, how to identify the cause of back pain, and managing physical health in people with severe mental illness. So let's get started.
Hello, good afternoon. I am Sajivika Ambarakon. I am a consultant ophthalmologist based at the Bristol Eye Hospital.
Welcome to the Clinical Update podcast. It's great to speak to you.
Thank you for having me.
I've just been to your talk. We're at MIMS Learning Live, which was really informative, and ophthalmology is something that we know GPs struggle with, don't get a lot of training on. I'm hoping that we can get a few key pointers for our audience now. So could you give me any tips that you have on how GPs can be consulting with patients around eye problems?
So I think one of the challenges that we have with ophthalmology for GPs is that it's a very unexposed area. One, the organ is quite small. It's a challenging area to examine. The patients are also quite symptomatic and it's very difficult for them to trust us to examine them. So I would say let's separate it into adults and children. So with children, one thing is that we can always do imitation in that we do examination on the parents first before we examine the child. We create a very child-friendly environment. So it's a very friendly room, non-threatening environment. Parents are there with them. The child, especially the young children, can be sitting on the parent's lap and show them the instruments that you're going to be using, the torch, the pen light, etc., and let them play with these instruments in the first instance to get comfortable with it before we do that. Additionally, for adults, it's to explain to them what we're going to do, how close we're going to get to them, and just explain to them the test before we go ahead and do the test. Another thing for children I find is drop installation is quite challenging. So what I tend to do is we can use normal saline drops and we can do the same on the parent. So again, do the test on the parent and then you do it on the child with actual drops.
Yeah, thank you. GPs, I would imagine, are concerned about missing anything serious that could have any lasting impact on the vision. What would be the criteria for referral that GPs should have in mind? So if we start with children again first.
Yeah. So with children, what we need to look at is age. So of course, younger the child, the more difficult it is to get all the signs and symptoms. So we tend to recommend that all quite young children, less than 2 years of age, likely would have a higher rate of referral to us. So when it comes to children, you look at the symptoms that they're having. Is it sudden onset of symptoms? If it's something that they've had just happen suddenly, so for example, trauma, if they had a blunt trauma or penetrating eye injury, that must be referred to us. Any children that have had sudden loss of vision, if they've had sudden deviation of the eyes, if there's a misalignment of the eye, if there's developed a wobble, which is called nystagmus in the eye, that's sudden onset, these are also dangerous signs of things that can be happening within the brain. So we would indicate that that would require quite an urgent referral. When it comes to young children also, if you're seeing things like poor red reflex, or you're assessing their red reflex and you can't identify it, these patients should be referred to us. Any patient with things like discharge, there is a bit of a gray area. You can test the discharge and see if there's any organism growing in the discharge and then treat it locally within the GP system. But otherwise, if it's a condition that's getting worse, progressing with the treatment on board, then we also recommend referral to the ophthalmic services. Anything that you're identifying a structural abnormality, I would say recommend to the ophthalmology services, because we will have a good look at the eye, use microscopic examination, and then assess the eyes properly to identify if there's anything problematic that we need to treat or need to be investigated. And then for adults, they're a little bit easier because you can get a better history. They'll be able to give you the actual symptoms that they're experiencing, and even you'll be able to examine them a lot easier and have the signs that you would need. So main things with adults are sudden loss of vision, sudden onset of double vision, limitations in eye movement, again, development of nystagmus, which is a wobble in the eye, visual field defects. Those are the main things.
And would these be urgent referrals?
These would be urgent referrals. Something a bit more that can be watched, treated, can be, again, conjunctivitis, things that would cause discharge of the eyes, a bit of redness in the eyes, but not causing any visual debility such as blurred vision, no obvious soreness or any obvious changes on the surface of the eye. Those can wait and be managed in the GP service.
In terms of the things like the nystagmus that you mentioned, what would be the criteria for deciding whether to refer to ophthalmology or to refer to neurology? Or would you put in a referral to both?
So I would say you can put a referral into both, but what would separate it is with nystagmus, if it's just nystagmus and nothing else neurologically, so you do a general physical examination. If they do not have any other deficits neurologically, such as weakness in any other part of the body, paralysis, any other neurological deficits in the rest of the body, then you can potentially just refer to ophthalmology.
Yeah.
But if you're seeing other symptoms and findings in the rest of the body, then I would recommend a neurology referral.
Yeah. So what are the things that you're seeing in ophthalmology, the common conditions that you think potentially could remain in primary care without needing to be referred to you?
That's a very good question, because we can be inundated with referrals, both GP and also ophthalmology. The most common things I would say is symptoms within the eye without any visual impairment as such. So patients who have dry eyes, they just have redness of the eyes, there's no changes on the surface of the cornea. These are patients that can be treated with lubricants, and they can be monitored in the GP system or telemedicine or video consultation. Conditions such as allergic eye disease, it's very common in our population, can be seasonal, can be just environmental. So in that case, we can do allergy testing and then seasonally treat these patients within the GP system. The times when I would recommend referring to ophthalmologists if they're seeing surface changes on the cornea, where then you need to have microscopic examination under an ophthalmologist, and I would recommend that. But otherwise, allergic eye disease is another one that can be managed in the GP system. Things like herpes zoster ophthalmicus. So a lot of patients will have periocular symptoms. So they have lid involvement of findings, and they're treated either with oral antibiotics or they're treated with antivirals, depending on the nature of the cause. But if there's no globe involvement, then these can also be safely treated in the GP system. If they're progressing or if they develop globe symptoms, then they should be referred to the ophthalmologist after that.
So to wrap up, what are the kind of key points that you would like GPs who've been at your session and GPs listening today to take into their practice?
Be comfortable with the equipment. Get to know your equipment. So basic things that you need in a GP practice, I would say, is a target, either a toy, a stick, lang stick, something that you can use as a target, pen torch, an occluder to do your cover testing, to look at each eye one at a time, assess each eye one at a time, and then the direct ophthalmoscope is a very handy equipment that we must have in every GP practice. Additionally, eye drops, things such as fluorescein dye, very important. Once you instill this, you're able to identify surface changes, any trauma, penetrating eye injuries. So all of these can be ruled out by using fluorescein dye. So you should have that in your medication box. Additionally, dilating eye drops. So that will help you examine the back of the eye much easier to do your fundoscopies. So we tend to recommend either tropicamide. So in children 6 months or less, we do 0.5%, and then 6 months and above, we do 1%. Same for the cyclopentolate, 0.5%, so 0.5% for children 6 months or less, and above 6 months, and adults we do 1%. And then phenylephrine, 2.5%. So all these three medications can be used to help dilate the pupil. That allows us to examine the back of the eye much, much easier. topical anesthetic drops are important. So for children, proximeticaine is the least stinging, so it's much more welcoming for the child, but you can use oxybuprocaine, tetracaine, lidocaine drops. So there are also other variations of topical anesthetics that can be used. Just good lighting, be comfortable with the equipment, practice examining eyes so that you become very fluid in examining these patients. Just like you use your stethoscope, just be comfortable with examining patients. Yeah. And anytime there's any worry, of course, refer. But once you've done all these checks, you checked vision and checked with the dye, etc., check the back of the eye, it's quite comfortable that you can manage a lot of cases within the GP practice.
Brilliant. Thank you so much. That's really helpful.
Thank you for having me.
So we've just had some really key practical pointers there on eye conditions, what you can manage in primary care and what needs to be referred. We're moving on now to a really common presentation, which is back pain, and we're going to hear from one of our expert speakers, Louise Warburton.
So I'm Dr Louise Warburton. I'm a GP and a GP with an extended role in rheumatology and musculoskeletal medicine. So I work in an interface clinic in Shropshire, in Telford actually, seeing all kinds of people are referred in, but my specialist area really is rheumatology. And I'm also the co-president of the Primary Care Rheumatology and MSK Medicine Society. I've been a member there about 35 years. I've got lots of experience of rheumatology, MSK conditions.
Very busy by the sounds of it as well.
I'm not too busy now. I work part-time, so I've got more time to come and speak at conferences like this.
That's great. Well, it's great to have you. Great to have you at the conference and great to have you on the podcast as well. So I wanted to ask you a little bit about back pain and what would be the red flags that GPs would want to be aware of in that presentation.
So back pain's so common, isn't it? People come in all the time with back pain and it's usually innocent or mechanical in cause. We want to just be able to spot those people who've got worrying causes. So the things which we look out for are big disc prolapses which cause motor weakness, so a foot drop or weakness in the leg, and then cauda-equina lesion, which is a more progressed form of that really, where there's a huge disc prolapse. It's affecting the nerves that supply the bladder, the bowel, the pelvis. It needs urgent action. It's been very much in the news recently. There are new guidelines for that. And because of that, I know the referrals to A&E with back pain have gone up hugely. It's important to spot the potential people with it. The other red flags are metastatic bone disease, because the population are growing older and surviving longer once they've had a cancer diagnosis, which is great. You know, if you've had breast cancer in your 50s and you survive that and then you live to be 80, then there's still a very small chance that you might have some disease in your bones and it becomes a metastatic bone deposit in the back. So that's another thing to look out for. Another very common cause, because people are getting older and living longer and are generally living longer with more chronic disease, is osteoporosis. So the osteoporotic wedge fracture of the spine. It's often, well, it is painful, but I know lots of women don't report it because they think, oh, I've just got quite bad back pain, I'm going to go to bed for a week. And then you do an X-ray or an MRI scan a few months down the line and you see that they've had a wedge fracture. So it's important to spot those and treat them, because the vertebral fractures happen earlier in the pathogenesis of the disease, and that can go on to then be a hip fracture 6 or 7, 10 years later. And 50% of people with a hip fracture over 75 don't actually come out of hospital. It's a major cause of death. So if you can prevent that, then we should be looking for that.
What would be the key presentations that would make you think of that?
Just quite severe back pain, and it's commonest in the thoracic region. The pain is referred down really, so although you might have a fracture of T8, people feel pain lower down in the back. And it's often brought on by a really simple act, like getting shopping out of the car, bending over, coughing or sneezing.
So disproportionate to the actual event.
And we're not encouraged now to refer people for back x-rays, but this is one of the occasions where you can. Because if you put on the request card, query vertebral fracture, they ought to do it quickly, urgently, and then you can see on the x-ray, get a report back that there's been a vertebral fracture.
And in terms of the metastatic bone disease that you mentioned, other than obviously a history of cancer, what would you be looking for there?
Well, that's a different type of pain. It's a bit like the fracture pain.
Right.
So it's unremitting. It's there all the time. It's there at night. It's waking the person up. They will feel unwell with it. They may lose their appetite, just feel generally horrible. So mechanical back pain tends to get better with rest, but metastatic bone disease won't.
Yeah.
And that can progress on to a cauda equina or a spinal cord compression, because the metastatic deposit can grow and compress the spinal cord as well.
And of course, cauda equina would be an emergency referral.
That's
then.
right, yeah.
So we've covered off some of the potential causes of back pain there. And in terms of inflammatory back pain, can you talk a little bit more about how a GP would recognise that, what they would do?
So inflammatory back pain is the presenting feature of spondyloarthritis. So that's one of the major causes of inflammatory, or types of inflammatory arthritis. So you've got rheumatoid, you've got spondyloarthritis, and the connective tissue disorders. So it's very underdiagnosed, inflammatory back pain. There's currently a 9.5-year delay in diagnosis for spondyloarthritis in the UK. I think it's 8.5 actually, but it's a long time. So people present in their 30s and 40s, but they get back pain, but it's not related to anything. So there are no precipitating features. They're just suddenly aware they've got back pain and stiffness. So they get a lot of stiffness in the morning. When they get out of bed, it takes them half an hour or so to warm up. They can't bend over and put their shoes and socks on. And this is young people, in their 30s. Why are they getting those symptoms? And then they usually get much better when they're moving around and exercising. But then as soon as they sit down in the evening, everything stiffens up again. They can't sleep because they wake up with stiffness and pain, and they can't turn over very comfortably. So all those features should make you think, why has this young person got back pain like this? A lot of people are dismissed. I have diagnosed many people in my clinic, maybe in their 50s, so later on in the journey of the disease. But they presented in their 30s and nobody realised what was going on.
Yeah.
So you diagnose it with a special MRI scan.
So something to be aware of then.
Yes, yeah.
So that's been a bit of a whistle-stop tour, but what would you hope to leave the delegates who come to your talk or the listeners to this podcast with? Any key points that you'd like GPs to take away with them? Taking
a really good history is absolutely imperative. I can remember starting in general practice and perhaps being 8-10 years in and dreading people coming in with back pain because I didn't know what to do with them. But I wasn't really equipped to take a proper history. If you can take history, considering the points I've been mentioning, the type of pain, what time of day is it, where does it radiate, is there any muscle weakness or pins and needles? So you can make a diagnosis just in 5 minutes.
Yeah, really narrow it down.
It helps to see the person as well. So I know we're doing lots of telephone consultations, but there's no substitute really for just watching someone walk in from the waiting room, how they walk, how they sit down, can they get up comfortably. Red flags, they're not common, you see. We all panic about them, but also it's knowing how to manage this. It's knowing how to advise people with simple mechanical back pain as well.
Yeah.
And not dismiss them.
Which would be rest and...
Well, keeping active, really.
Is that?
Yeah, so the worst thing you can do is go to bed and lie down and not do anything. So although it's painful to keep moving around, take simple analgesia like paracetamol or ibuprofen. And if you do have any of these red flag features like weakness or pins and needles, or you can't pass urine, or you can't sleep because of the pain, that's more significant and probably a urgent referral for an MRI.
Yeah.
But generally just keep moving. Moving is medicine, according to the Faculty of Sports and Exercise Medicine.
Good advice, Thank you so much, Louise. It's been great to speak to you.
Thanks.
So that was a great quick run through of a really common primary care presentation. Now we're going to be changing tack again, and we're going to be moving on to hear about serious mental illness and the intersection between that and physical health.
I'm Helen Pears. I'm a consultant general adult psychiatrist. I have a background in community mental health team work in Merseyside, and currently working in an adult ADHD service.
It's great to have you at MIMS Learning Live this year. Really enjoyed your talk that we've just listened to.
Thank you.
So could I ask you to talk a little bit about serious mental illness, which is what you've been presenting on today, and the impact that that would have on someone's access to care and what GPs could do about it, importantly, as well?
Yes, absolutely. So serious mental illness, usually the term is used to encapsulate the more chronic mental illnesses such as schizophrenia, bipolar disorder, severe depression. And those people have a really quite markedly worse life expectancy and health outcomes than the general population. So people with severe mental illnesses, shockingly, their life expectancy is thought to be 15 to 20 years less than the general population. Wow. So we're dealing with a cohort of people who are really quite physically unwell. It's exacerbated by difficulties with their access to healthcare. And despite our good intentions to try and make our healthcare accessible to all, this group have particular difficulties, which is one of the things I was talking about today, with accessing both GP appointments, but also outpatient clinics, hospital appointments, etc. One of the main issues that they have is that many people with severe mental illness get what we call the negative syndrome, so negative syndrome of schizophrenia in particular. And that can affect their executive functioning, their ability to plan, to use their working memory, to prioritise and organise things. Yeah. It makes it very difficult for them to organise and get themselves to appointments in the first place. Yeah. So we talked today quite a bit about the fact that some people with SMI, quite a lot of people with severe mental illness, will struggle, for example, to manage the tasks that lead to getting yourself to an appointment. So opening post, managing letters, responding to the myriad text messages that we get from health services these days, to remain on waiting lists. They might struggle with travelling to appointments due to symptoms or due to side effects of their medications. Unfortunately, they're often in more deprived sort of socioeconomic groups and struggling with poverty as well. So the costs involved in getting to appointments can be a real issue for them. They can also have quite a lot of anxiety about appointments and about feeling that they might be treated as though their issues are to do with their mental health problem rather than physical health problem, which we kind of call overshadowing. So we were talking today really a bit about what we can do about that and how healthcare professionals can just take practical steps really to help people with SMI to engage better with the care they're trying to provide. So I can go through there's various tips that might be useful.
It'd be very useful to have some tips for our audience, definitely.
Well, if you split it, I suppose, into the stage prior to the appointment, and then after the appointment. If you look at prior to the appointment, I think it's always useful to consider, if you're able, whether a patient's going to attend for their appointment in the first place. Yeah. So early on, if you are aware the patient has severe mental illness, it might be worth considering what adaptations could be offered. Could the appointment go, for example, to their community psychiatric nurse or be copied to, with their permission, obviously? Could it go to their carer, or it might be in supported accommodation? Could it go to them? The other thing that I think we probably don't consider enough is whether they could be accessible, or they could access patient transport, funded patient transport. Having looked up the criteria for those, it does include mental health conditions that means they're unable to travel there alone or to make their own way, in fact. So that would cover quite a lot of people with severe mental illness and could, I think, make quite a difference, although we don't see it happen very often. I think if then the patient is in front of you and they're at their appointment, certainly something I do in psychiatry appointments is get details from them early on as to how to make contact with them again. They may have a mobile number on their records, and we're all aware that those change frequently, but often the actual number that's best to get them on isn't on there, particularly if they're in supported accommodation. The office number will usually be the best number for that, and so just asking them for the best way to make contact in future, I think, is really helpful, and keeping a record of that, obviously updating it regularly. Alongside that, again, formally recording whether they want their appointment copied to someone or someone's, several people, may be useful. They may have social work input or CPN. They might have a carer in order to help them attend. And I think making it clear they can bring someone with them to the appointment to help them both get there, get home, and to understand what's going on in the appointment. Not because their severe mental illness necessarily affects their ability to understand, but their ability to retain what's been said. They may become more overwhelmed with information than if they didn't have a severe mental illness. So it can help to have someone there to also take note. In the appointment, it might be useful to consider whether future appointments need to be a bit longer, which clearly is difficult in the current climate, but if available, that's a useful thing. Thinking about waiting areas, some of our patients with severe mental illness find the waiting aspect as difficult as the appointment, particularly if there's a lot of noise in the waiting area or the news on, particularly those people with trauma can find that hard. Asking about the timing, sometimes having a later appointment can really make a difference for people who maybe have medication that's quite sedative. And I think the other thing I would say is written information, both handouts and that kind of thing, or web links, although I think paper is probably better. And writing down, I think, a short few lines as to what happened in the appointment, who you saw, what next, where will you get your medication, what will it be, how should you take it. I do that in psychiatry outpatients and have done for ages, and I think it does make a big difference just when people are anxious that they can refer back to it, or they can give it to whoever's supporting them. And I think that helps to make their ability to retain the information easier. And then the last thing really, I suppose, is trying to make every contact count. So for people who are struggling to get to appointments, trying to link them in with screening or with health prevention programs when you do see them. I think making the most of that appointment and keeping in mind that it might be a struggle for them to get back is really useful to keep in mind.
Yeah, really, really useful tips there, and very interesting about the patient transport as well, because I'm sure that might not have occurred to some of our listeners that might be an option for their patients. So That's very useful.
It hadn't occurred to me really until it happened for somebody that I saw, and I thought actually there must be a lot more people eligible for that than perhaps use it.
Absolutely. So moving on then to the impact of serious mental illness on interactions. We talked about a bit in your presentation, didn't we? Can you give me a few key pointers on that?
We just talked about a few common interactions and side effects that we see with mental health medications. One of them was fluoxetine, obviously commonly prescribed and a useful antidepressant, which has a long half-life. So that can be really useful if you're looking for a medication that doesn't have an SSRI, that doesn't have a withdrawal syndrome. But it is also a potent CYP450 enzyme inhibitor, which means that there are quite a few interactions that increase levels of various common drugs, including codeine and tramadol, also metoprolol and bisoprolol, tamoxifen, gliclazide and metformin. And it can reduce the potency of clopidogrel. So it's one of those medications, I think, that if it's being stopped or started in somebody who's on the other medications mentioned, it's worth keeping in mind that the efficacy of those medications might change, the dose might need altering. We also talked a bit about clozapine, which listeners will be aware it's a third-line antipsychotic and very effective, but does require monitoring of white cell count, which is one of the reasons why it's third line. Side effects can be an issue with it, and I think most of us would be aware of things like weight gain, but some of the other side effects can be overlooked. Hypersalivation is a big one. People on clozapine are at a much higher risk of getting recurrent chest infections and pneumonia, and one of the factors may be hypersalivation with aspiration, particularly during sleep. So a useful tip for people who maybe are getting recurrent chest infections on clozapine is to have them sleep more upright, to sleep on an absorbent surface like a towel. Can help to stop the saliva pooling and then them aspirating in their sleep. We also prescribe hyoscine just to dry the saliva and reduce the output a bit. The other main side effect to be aware of is constipation,
Right.
and treating constipation early with clozapine, because it can become very severe, and there have been cases of obstruction and perforation. All the side effects with clozapine, myocarditis and cardiomyopathy, are very rare, but again, things to think about in people who are presenting with cardiac symptoms. And it can reduce seizure threshold. So with clozapine, if you miss it for 48 hours, you have to retitrate it. And therefore, people do miss it and sometimes will be stopping and starting clozapine, and obviously keeping that in mind if they're having seizures, that it might destabilise their seizure control.
That's very useful, particularly because, of course, I would imagine in the SMI cohort there is a lot of comorbidity. So drug interactions would be very, very important. That's been very helpful. Were there any key pointers then that you wanted our listeners to take away from this podcast episode?
I think really just the very, unfortunately, still very poor health outcomes in the group. So I think keeping them in the forefront of your mind, that even quite seemingly minor interventions can have a really positive effect. For example, smoking cessation. It's enormously important, I think, to try and target that group for health preventative measures. Although it can be frustrating if people aren't turning up for their appointments, continuing to try and put measures in place to get them to appointments, again, could have such a huge effect in this group. They do often struggle as a group to advocate for themselves. So I think perhaps just keeping them in mind, really, that's the main thing.
Yeah.
As a cohort, you can really make a huge difference in.
Yeah, really, really important point to finish on. So thank you so much, Dr. Pears. It's been great to speak to you. Great to have you at MIMS Learning Live as well.
Thank you very much. A pleasure.
Well, that's it for today's episode. I really hope you've enjoyed it and have gained some key pointers to take into your practice. For more from MIMS Learning Live North, go to our website, mimslearning.co.uk. And while you're there, don't forget you can claim CPD certificates for listening to this podcast. Thank you to my guests today and to our producer, Jude Owen. And thanks, of course, to you for listening. There's no episode next week. We're taking a break for Christmas. But I hope you'll join me again on New Year's Eve for all the highlights from this season of the Clinical Update podcast. See you then.